Welcome to the March 2025 Talk with the Doc with Dr. Timothy Leichliter of Allegheny Health Network. Thank you everyone for joining today live, or maybe you're watching the recording. And thank you, Dr. Leichliter. Please take it away.
You're welcome. Thanks for having me again. Star seems a bit of a stretch, but I'll take it. Welcome, everybody. We're back to March. Man, time is flying. Still cold outside. If you've been here before, if you haven't been here before, I'm Dr. Leichliter. I don't want to say self-proclaimed movement disorder specialist here at Allegheny Health Network, but such is life. If you have been here before, welcome back. If you're my patient, hi. If you're not my patient, hi. Generally, this is a good question and answer session. And so as Casey mentioned, the best way to get your questions in is to type them in the chat box. I do have a handful that I'll start with in my emails, and then I'll go to the ones in the chat box. As usual, my usual caveats for this type of a talk are this is a good general information session. It's not a great place to get one-on-one directed care. You're better off discussing that with your doctor or care provider. And the other thing I like to say is that everything you hear is indeed my opinion. I have a lot of opinions. I don't mind sharing my opinions. I will give my opinion on just about anything you ask about. But it isn't nonetheless my opinion. I like to think my opinions are based on as much medical evidence as I can muster, but well, sometimes I just make stuff up, in which case I will let you know. But it does happen. We got blackberry green tea today. Haven't tried it before. We'll see how this goes. And with that, I will start with the two emails that Casey already sent me, and then we'll go from there. So the first one was actually about an article that was sent to me about a new study. The headline is "New Study Uncovers a Shocking Side Effect of Parkinson's Drug." Well, again, always interested in reading stuff about that. This is out of the University of Vienna, was just published in last month, February of 2025. And the long story short, I'll kind of wrap this up in a nutshell, is they looked at entacapone, which is Comtan, which is one of our COMT inhibitors that we use to try to extend the life of each dose of carbidopa levodopa, and they basically tested it in to see what it does to the gut microbiome. And what they found was that it does indeed change the gut microbiome and causes difficulty with iron. And they were questioning whether or not this is a problem, whether this should be looked at. Do we need to be worried about iron absorption or iron regulation through the gut? And are the drugs that we use for Parkinson's disease causing problems in iron absorption and or synthesis? I don't make a lot of this study, in all honesty. I read through kind of what they published here, and I got a lot of questions about it. So for one, they took stool from healthy subjects, they incubated it with theoretical appropriate dosages or therapeutic concentrations of these drugs, and then they using a bunch of spectroscopy and fancy equipment, they then evaluated the gut microbiome. I have no idea how they came up with this study. I don't know why they took stool from healthy populations. I have no idea why they picked entacapone to look at. I use Comtan not all that frequently. If you're really looking in Parkinson's disease, why not use Cinemat? I don't quite understand why they did what they did, nor do I necessarily know how to interpret the results. Now, again, when it comes to Parkinson's disease, we have known that iron problems, either deposition in the brain, regulation, movement throughout the body. I mean, we've known this for 20 years. We've known that iron is a problem in Parkinson's disease for a really long time. There are studies that go back a long time that have been looking at Parkinson's disease and iron and how the two go together. Iron is well known in restless legs to be a problem. So none of this is really new from an iron standpoint. I'm not really sure. We've never really known how to use that to our advantage or what that means in the pathophysiology of Parkinson's disease, but we've known there's always been a correlation there. That's not new news. I'm not entirely sure, again, the rest of the study, how to interpret the results. And so, again, I think I would hold off on being wowed or overwhelmed or change my plan based on that study. I would want to see kind of the actual publication, why they chose what they did, what they think it means, so on and so forth. They also didn't pick people with Parkinson's disease, who we know the gut microbiome in people with Parkinson's disease is not normal or is different than normal people. So I'm not really sure what they were going for here. Interesting theory or idea, I guess, but I would need a whole lot more information before I think too much of this study like that. Can I explain the differences between Parkinson's primarily affecting the upper body versus the lower body? Sure. And so the obvious answer is some people come in with hand tremors and some people come in with stiffness and walking problems. The much more detailed answer is a couple of things. So historically, we used to look at or try to group people with Parkinson's disease into symptoms that they present with. So historically, you would always hear us talk about tremor predominant Parkinsonism or Parkinson's disease and akinetic or bradykinetic rigid Parkinson's disease. And for a long time, there was a philosophy that people who came in with predominantly rigidity, difficulty picking up their feet, magnetic gait, and not a lot of tremor did worse than the tremor predominant group. More recently, we've gotten away from that because it turns out that's not necessarily accurate. There's a whole lot more that goes into kind of making those thoughts, those ideas, those recommendations. And so we've gotten very, very far away from kind of grouping people in their presenting symptom diagnosis. The other thing that I would comment on that is you often hear me or us talk about lower half Parkinsonism, which predominantly affects the legs with very minimal tremor, very minimal symptoms or stiffness in the arms. And this is usually a reference to a vascular Parkinsonism. So if I see somebody who comes to my office and they have vascular risk factors, that they've had strokes, or maybe they're a little bit on the older age side, or maybe they're on a lot of blood pressure or diabetes medicines, and they come to me with a diagnosis of Parkinson's disease or Parkinsonism or Parkinson's symptoms, but they really don't have a lot of resting tremor. They really don't have a lot of stiffness. But as soon as they get up and start walking, you can see that they're shuffling. They have trouble picking up their feet. The first place I'm going to look is an MRI. Because most of the time when I see that person, you see a lot of vascular changes surrounding the fluid-filled spaces in the brain. And that in and of itself tells me that that's more of an atypical Parkinsonism, not a true typical Parkinson's disease. And I would call that lower half or vascular Parkinsonism. Now, that doesn't necessarily change what I'm going to do. It doesn't change the medicines that I use. It doesn't change me yelling at you about exercise or harping on you about therapy. The underlying kind of plan of action isn't all that different if you have Parkinson's disease versus some of the atypical Parkinsonisms, but it does give me an idea of what to expect. So if you have a lower half Parkinsonism or a vascular Parkinsonism or an atypical version, it doesn't always respond as well to the medicines. It doesn't always progress at the same rate. It's a little bit harder for me to predict. And so that's where you'll see me use these terms. And that's probably the biggest difference that I would say between people who have upper body affected and lower body affected. But realistically, what we do is very similar. I once took a sniff test at least 6 years ago to determine if I had any loss of sense of smell. So they actually have cards, they have vials. There is actual formal testing that you can do for somebody's sense of smell. I don't do it in my office, but some movement disorder specialists do. At that time, I still had good results. But within the last year, I have lost most of my sense of smell. At this point, is my sense of smell gone forever? Or is there something I can do to change the trend? Since I live alone, I've had to rely on neighbors to tell me a variety of things. My answer is I have not successfully found a whole lot of things that really resurrect sense of smell or sense of taste for that matter, because those two things go hand in hand. We do know that anosmia or loss of sense of smell is a predisposing symptom of Parkinson's disease or a prodromal symptom of Parkinson's disease or Parkinsonism. We have not quite figured out why that is. Going back to some of the hypotheses, the Brock hypothesis about where Parkinson's disease starts and how it spreads, there's some thought that it starts in the gut, works its way up the vagus nerve, gets to the olfactory bulb first, and then works its way to the brainstem, which is why they proposed that that's why you see that trend. However, there's a lot of question marks about that data, about how they came up with that hypothesis, but you'll still hear about it. We don't really know the answer to this question, but it does seem like loss of sense of smell is one of the premotor symptoms that we see, along with REM behavior sleep disorder, which is acting out dreams, and constipation. I have not had a lot of success treating Parkinson's symptoms and finding that sense of smell gets better. I have not had a lot of success with levodopa or the dopaminergic medications. I really have not had a lot of success resurrecting sense of smell. Um, I feel like somebody told me that B6 or not B6, B1, the guys who were doing the high doses of B1, vaguely remember one of them telling me that his sense of smell did improve. And so maybe there's something to that. I would need to see a lot more people have that effect before I start touting that or telling people, yes, you should go do this. But again, something to think about. But in terms of basic treatments or day-to-day treatments for Parkinson's disease, I have not had a lot of success with sense of smell. I'm always open for suggestions if people have had success with other things. Is it okay to take other medications or supplements at the same time as carbidopa, levodopa? Example, cholesterol medicines with carbidopa, levodopa. Sure. The one thing, and this is a lot of trial and error. From my standpoint, there's not a lot of things that I tell people they can't do with their pills, supplements, take medicines. Generally, I don't find a lot of interaction or things that make it less effective. Now, the caveat to that is protein can interfere with the absorption of levodopa, so food can. But I don't think I've ever run into somebody who was on a Lipitor or a cholesterol medicine or a diabetes medicine, and they found that their Cinemet didn't work as well. And so I do not usually kind of counsel my patients or caution my patients or say, oh, take this by itself, kind of like you have to do a Synthroid, where you have to take that first thing in the morning without taking any other medicines or any food or anything like that. I don't think levodopa is necessarily as affected. If you find, and everything we do is trial and error. And so if you find that, hey, my atorvastatin or my whatever drug does seem to make it less effective, then just split them up. But I can't think of any that I necessarily tell my patients, oh, you can't take these together. Even from a supplement standpoint, I can't think of any supplements that I would caution and say don't take with your levodopa. None that I've come across of lately or recently. What are my thoughts on the new apomorphine infusion device, a NAPGO? I will tell you as soon as I get to play with it. So it's not technically available yet. From what I've heard, maybe later this month, beginning of next month. I think it's interesting. Much like Vyalev, which is the levodopa infusion. I have tried that one a couple of times. I've found it interesting. I'm a little bit, I don't want to say frustrated, but frustrated by the restrictions in terms of who I can get that for just yet, which it turns out are young people on commercial insurance, which is significantly the minority of my patients. Um, Again, I'm hoping that maybe until that one gets approved by Medicare, when an app goes ready to go, I can use it more frequently or get it better, distributed from my patients. I'm still trying to figure out how I'm going to use it in my clinic. So for those of you who don't know, apomorphone is a dopamine agonist. This has been around for a really long time. I'm not sure how long. I should have fact checked that one before I got on. It was historically known as Apoquin. So this was the injectable medicine that you could use as a rescue medicine. For a flirting period, it was Kinmobi, which was a thin strip that dissolved on your tongue that I actually could not remember for the life of me the name of that last talk. But so that's the drug that's in an APCO. So the drug itself has been around a long time. Turns out this infusion pump has been around for a long time in Europe, but it just finally got here to the United States. They have a lot of good experience with it in Europe, a lot of data in Europe. But again, I like to get my hands on thing and start using it. I think it's going to be another adjunctive medicine. So I don't think initially it will necessarily take the place of medication when I started in my patients. It may take the place of something like Requip or Mirapex or Nupro. That's the same class of medicine. Um, but I'm still trying to figure out where I'm going to use it or when I'm going to go to it. And I think I just need to get some more experience with it. And so I will have thoughts on it. I have thoughts on everything, and I already have thoughts on it, but I'll probably have more thoughts on it once I can actually get my hands on it, start using it in patients, start seeing what it's good for, what is it not good for, what does it work well with, what does it not work well with, which type of patient does well with it, which one doesn't. Going back to the Apoquin, we used to run into some problems of blood pressure, so that was something we always had to keep in mind. And so there are going to be some caveats here and there in terms of who I think is a good patient for it. But the short answer, after a really long answer to your question, is more to come. more to come once I actually get to play with it, and then I can let you know kind of my experience with it. And then the other email that I had, does Parkinson's cause increased pain from another condition? For example, the person has Parkinson's and tendinitis. The tendinitis is flaring. Will the comorbidity of Parkinson's increase the pain from tendinitis? And if so, how do you recommend managing the pain? And the short answer is yes to all of the above. So a lot of my patients also have other things. And it not only does Parkinson's disease lead to other things are also very common. So take things like tendinitis, spinal stenosis, arthritis. These are very common. You don't have to have Parkinson's disease to get tendinitis or lumbar spine arthritis or back pain, right? Very, very common things. However, if you are somebody who has Parkinson's disease and your walking mechanics are wrong and you're flexed forward and you don't swing your arms and you take short shuffling steps and you don't come down on the correct part of your foot, guess what? You're going to put a lot of stress and strain on all of those joints and muscles and tendons, and they're going to flare up. This is why a lot of my patients do end up with bad knees, bad hips, bad backs, bad necks, bad shoulders. The entire chain, top to bottom, is put at a mechanical disadvantage because your posture and your walking mechanics are incorrect. And so at the end of the day, a lot of my patients end up with these other conditions. And so the short answer is yes. Having Parkinson's disease, which puts your mechanics in an improper technique and movement, is definitely going to be a cause of flaring up tendinitis, arthritis, spinal stenosis, so on and so forth. I don't necessarily recommend anything different outside of trying to work on walking mechanics, movement mechanics, and a lot of physical therapy for stuff like this. A lot of paying attention to posture, standing up straight, shoulders back, all the things that your husband and wife, probably mostly wives, harp on you about. But at the end of the day, actually treating the tendinitis or the arthritis is the same. It's using anti-inflammatory medicines. I send a lot of my patients for hips and back and knee injections, or whatever else the pain guys or the sports medicine guys or the rehab guys can do. The end result or the treatment strategies are relatively the same. Yes, one can flare up another, but treatment is still relatively aimed at decreasing inflammation and helping to treat pain. I wake up early around 4 a.m. some mornings. What awakens me are the negative thoughts and dreams about myself or family members. I can't get rid of the thoughts sometimes. I get up and take a Cinemet, and those thoughts resolve, and I can go back to sleep. Any thoughts or recommendations? So I thought that was fairly interesting. Um, a lot of my patients have vivid dreams. Vivid dreams, REM behavior sleep disorder come with Parkinson's disease. So acting out dreams, yelling, kicking, fighting, punching, throwing yourself out of bed. This is a non-motor symptom or a premotor symptom of Parkinson's disease that very, very, very often leads to Parkinson's disease. A lot of my patients also have fairly vivid dreams. Now, a lot of my patients say they're not bad. They're just vivid. I dream about people I used to work with 20 years ago. No idea why. They just come to my dreams. Or I dream about family members, but they're not usually bad, scary, or negative. However, I do have plenty of patients where they have negative dreams, they have nightmares, they are bothersome. And so part of that is the disease itself, which lends itself to these dreams. But the medicines also, in my experience, tend to flare that up. So carbidopa, levodopa, mirapex, these medicines also tend to give people vivid dreams, along with hallucinations. And so while I'm not sure why getting up and taking a Cinemet would help that resolve, if it works, it works. I don't ask questions when good things happen. But at the end of the day, I would probably treat that. If somebody brought that to my clinic, I would probably say, well, why don't we treat it the same way I would treat either REM behavior sleep disorder, which would be melatonin or Klonopin, or night terrors or night dreams, which would be more like prazosin, which is a cardiac medicine. But I would use kind of the medicines that I would use for them if it was a problem and if it was bad enough. If you came to me and said, hey, you know what, sometimes I wake up at 4 a.m. with these bad thoughts, bad dreams, but I take a Cinemet and I go back to sleep and it's not a big deal, I'd say keep doing that. That's just my opinion. If you're not my patient, don't do that based on my recommendation. If you are my patient, you should probably still let me know what you're doing. But at the end of the day, that's probably how I would go about tackling that problem. Again, dreams are pretty common. Bad dreams, not as common, I would say, at least not in my experience. I really like this next question. Why, oh, why am I always sleepy and fatigued? I average about 7 hours of sleep each night. I feel rested when I first get out of bed, but within an hour or so, the tiredness is present. I haven't had any blood work recently. I take vitamin D. Any recommendations? Well, a lot of reasons. So, the number one complaint I get in my office is fatigue. The number one overarching kind of theme in my office is frustration. But I think the number one complaint that I get in my office is indeed tiredness, fatigue, lack of energy, lack of motivation. And this is not proven. This is my opinion. And I say this is my opinion because I've brought this up to patients and they all tend to agree with me. So you tell me what you think. My personal belief about the sleepiness and fatigue in Parkinson's disease is that it is a mental fatigue and tiredness and not a physical fatigue and tiredness. And so what I mean by that is it does not feel like, oh, I just ran a marathon and my legs are tired. This is a mental or an emotional fatigue. And I think this is not proven, or I've never read this anywhere, but I think it's because you have to put forth brain power, energy, and effort and thought process to do every little task or movement that you want to do. There's nothing that you can't do. You can take big steps. You can stand up straight. You can swing your arms when you walk. You can talk at a loud voice. You can write your name large. But every single one of those things requires brain effort, brain power, thought. You have to think about each and one of those things in order to make it happen. Presumably I'm a normal person, but normal is quotation marks. But I don't have to think about those things. I don't think about every step that I take. I don't think about picking up my foot, swinging my arms, well, my posture's pretty bad. I should probably think about standing up straight, but I don't. But these things just naturally happen when I get up to walk down the hall. These things do not naturally happen when you get up to walk down the hall. And so it requires that extra brain thought, that extra brain energy, that extra effort to make those things happen. And because it requires that extra thought, that extra brain power, I really do think that's very fatiguing and tiring. And that's where a lot of the fatigue comes from. Um, and this is why, in my experience, I have not found a very good medication to treat it. I have tried everything in my patients. I've tried more dopamine medicines. I've tried antidepressants. I've tried stimulants. I've said drink more coffee. Sometimes that works, sometimes it doesn't. I've tried every medicine under the sun that I can think of, and I have yet to actually find a medicine that consistently people come back and say, I feel like I have more energy. I'm less tired. I'm less fatigued. Even the stimulants, you would think that those types of medicines would help, and maybe they do a little bit, but I have not found even a stimulant medicine that consistently comes, or patient that comes back and says, yes, this gives me energy. I'm less tired. I'm less fatigued. In fact, you're going to get tired of hearing me say this, but the only thing in my 10 years of experience that really has helped people from that energy level is exercise. I do find that when people get up and they move and they exercise, they feel less tired and fatigued. Now, again, I don't know how that would work from a brain power standpoint, but at the end of the day, that's what I've had success with. But that's why I think the number one complaint I get in my office is tiredness and fatigue. And again, if you think about it, that doesn't matter or make a difference how much sleep you get. That doesn't matter, and that would explain why you would feel better when you wake up in the morning and get worse as the day progresses. I mean, they should check some blood work. You should go to your PCP and you should bring these up because if your thyroid's off or if your D is off or B12 is off, I mean, there are other things that can make you tired. And just because you have Parkinson's disease, that does not make you immune to everything else. But at the end of the day, that's my experience. In terms of recommendation, obviously it's exercise. First and foremost, exercise is absolutely the best medicine for you. I did sit through a lecture a couple of movement disorder society meetings ago where they talked about light box therapy, giving people energy where you sit in front of a bright light. Since especially, again, I don't know if you guys noticed, but we don't get a lot of sunlight here in Pittsburgh, FYI. Turns out sunlight is really good for you. And so sometimes light box therapy has been shown to help, but I'm not entirely sure what the numbers are of the voltage of the watt or the wattage of the lights and so on and so forth. That would have to, we'd have to look that up. Supplement wise, most patients are B12 and D deficient. So, even if you're borderline taking those, they may help. But I really haven't come across much from a supplement or a medication standpoint that really gives people energy. It's one of those things that's really hard to fix. And then the last one that I have an email. I'm 62 and I was diagnosed 3 years ago with Parkinson's disease, and I'm just now trying medications. I have right-sided symptoms. I've tried 2 different medicines unsuccessfully because of side effects. When is the time to consider deep brain stimulator surgery or just continue other medications? This is also very subjective. We all, and when I say we, I mean me and kind of people in my community, all have different ideas, different philosophies on the right time or who is the right candidate for surgery. So just to take a step back, deep brain stimulator surgery is a surgery where we implant wires into your brain, hook you up to a generator in your chest, and we can electrically help control some of the symptoms in Parkinson's disease. It's another treatment strategy that we have, much like high frequency ultrasound ablation or medications. These are other or alternative, or I always say more aggressive or invasive things. And there is no right time. I'm going to put that out there first. There is no, this is the right time for everybody for surgery. It is very, very individualized. My opinion or preference is that I like you to have disease for at least 3 to 5 years because that's what we've looked at in studies. Although in Europe, they are much, much more aggressive from a deep brain stimulator surgery standpoint than we are in the US. They are much quicker to get people to the operating table. They do it really after just a couple of years of diagnosis if you have the right symptoms and the right things. And after that, if we've tried some medicine, we're not having as much success as we would like, you're having side effects, that's when I start thinking about surgery. Um, I would not give up after 2 medications. I can come up with a whole bunch of other versions or other medicines, particularly if it is a side effect problem. Then I would keep trying different things to see if I could find a medicine that you would tolerate. But let's say we try a few more. Let's say we're just not having a lot of success, or it goes another year or so, then yeah, I'd be getting you to the surgeons to talk about what other options we have. Again, I don't give up after just a couple of medicines. I got a whole host or regimen of medicines that I would try. But again, I also am well aware that every single medicine that I have has a price, has a side effect. And so, I can't ignore that either. And so that's where you start to kind of use judgment in terms of who's the right person, when's the right time, what symptoms are we trying to accomplish or take care of. These are all the things that, what other medical problems do you have? What other medicines are you on? For instance, if you're on blood thinners, that definitely makes surgery a little bit more challenging. And so it's not just this person, this age, this diagnosis. There's a whole lot that goes into that decision. And that's really a back and forth conversation between you and your neurologist, or you and your movement disorder specialist, or you and your doctor. The caveat to that is I wouldn't be against getting you to the neurosurgeons to discuss the procedure. Just because you talk to a surgeon does not put you on the hook for surgery. But that, again, when we're starting to think about it and you want to get more information about it, that's not a bad choice either, to at least start the discussion and then continue to work with medicines and see how you do. All right. Well, that was all the questions that I had in my box here. So let me go take a look and see what's in the chat box. And again, keep throwing questions in and we'll go from there. Casey, can you share the article? I don't know. I'll leave that up to you.
I
Does
did.
be okay, perfect. I didn't get that far. Does being sick with things like the flu make Parkinson's symptoms worse? Yep. Is there a lasting effect for a certain period of time? Yep. I recently had the flu and was sick for 10 days, and it's been 3 weeks now, and I don't seem to have rebounded yet. Yep. The short answer is yes to all of the above. And it's not just the flu, in case you were wondering. So any type of infection, anything that stresses your system, probably most commonly I see urinary tract infections, but your UTIs, the flu, COVID, pneumonia, severe dehydration, anything that lands you in the hospital, make Parkinson's disease symptoms worse. In fact, if somebody calls me or sends me a message and says, so-and-so was doing okay, and then all of a sudden he woke up and he couldn't move, or all of a sudden he woke up and was hallucinating like crazy and confused out of his mind. The first place I look is for a urinary tract infection, because that's where it most commonly comes from. But any type of infection, any type of thing that stresses your entire system, makes your Parkinson's disease symptoms significantly worse. Parkinson's disease, and I'm not telling you guys anything you don't already know, is a slowly progressive condition. It gets worse over time, but it usually gets worse over time in a fairly steady, slow fashion. If somebody acutely gets worse or abruptly gets worse, something else happened. Parkinson's disease should not all of a sudden get significantly and severely worse. Again, anytime my patients call me with that, I look for something else. Either you had a stroke, an infection, a flu, a COVID, your electrolytes are off the chart, something else is going on to trigger that. And everything else that you mentioned is equally accurate, which is the problem when I tell people that is they think, okay, I'm going to take an antibiotic, I'm going to clear my urinary tract infection, and I'm going to go back to how I was. And that's the goal, but I'm going to give you a hint. That is not real life. Usually what I tell my patients is that, let's say they put you on antibiotics for a week. It then takes another few weeks before you really recover to where you were before. And it does not always get back to where things were before. These types of things can progress the disease in somewhat of a fashion. And so I would not be, if you were sick for 10 days, I would not be surprised that you're still not back and doing better after a few weeks. I would expect that to take significantly longer. I don't know why that is. I can't explain that pathophysiologically, much like I can't exactly explain why urinary tract infection makes you shakier and confused. But they do. And so at the end of the day, you just have to give it more time. And you should be aware that not everybody necessarily recovers completely from their infection or from their flu. And so you just should keep those things in mind. General rules of thumb are give it a few weeks after you finish the antibiotic course to really start to see the improvements. Again, I can't really explain why that is. I don't know why that is, but that's just what I see time and time again. But I think everything that you explained in your question is pretty typical, and very common for what I'm used to seeing in my patients. I don't know the answer to that question. How does exercise help Parkinson's? It just does. Okay. Um, period. The end. Take my word for it. That sounds like a terrible answer. It's because I said so, right? We don't really know. So blood flow, stretching muscles, strengthening muscles, is one type better than the other? Maybe. So we don't really know how exercise helps people with Parkinson's disease. There's a lot of theories out there. I have my own philosophies on this, and realistically, I don't really care how it helps. It just does. We're not sure if it's just purely musculoskeletal. Again, strong muscles, better stamina, help people walk better, do better, move better. Is it because of the cardiovascular benefits? Your heart pumps better, your lungs work better? Maybe. Is it that with exercise that really gets blood flowing and it cleans out cellular debris a little bit better? So every cellular process in your body and in your brain has some sort of byproduct, and those things have to be removed for cells to function correctly. And it seems like exercise does help with that. Does exercise help the mitochondria function better? So the mitochondria are the kind of energy producing parts of your cells. And we well know that mitochondria are impacted in Parkinson's disease, and this is part of the cellular dysfunction that we think leads to the loss of the dopamine cells that require a lot of energy. And is it that exercise helps these mitochondria function better or stay alive longer? I don't know. It's probably a combination of everything that I just mentioned or nothing that I just mentioned. But at the end of the day, it does. There have been some studies to suggest that some exercises are better than others. I remember seeing a poster, I think it was at actually the last Moving Well conference, that suggested that dance and boxing were statistically better than maybe some of the other exercises. I think I remember seeing a poster at a conference that said that swimming was supposed to be one of the better exercises comparatively to, in my opinion, no, one is not better than another. Because if I tell you that dancing is the absolute best exercise on the planet, but you hate dancing, it's not the best exercise for you because you're not going to do it. And so at the end of the day, I don't think that one exercise is necessarily better than another. I think a variety of exercises are good. And this is where I'm going to get into my opinion. The one thing that I do caveat patients to is I do remember seeing a poster or a paper that suggested that just stretching is not good enough. It has to be more than just stretching. Now, more than just stretching can be just about anything else you can think about. It can be brisk walking, it can be running, it can be dancing, it can be Tai Chi and yoga, which also work. It can be ballet, it can be stationary bike, it can be swimming. I don't really care. To me, they're all good, and one is not necessarily better than another. I think if you find something you enjoy doing, you will be much more likely to do it. And if you're my patient, I'm going to ask you to do a lot of it, and I'm going to ask you to do it forever. So you better find something you like to do, otherwise it's going to be a lot of work. My personal belief, and this is my personal opinion, is that a combination of aerobic exercise, strength training exercise, and balance training exercise is probably your best overall combination. But how you come up with those, dealer's choice. Take your pick. Find ways to do it. I can try. Can you explain the feeling of having an internal tremor at the end of my on time as I start to go off? Well, I think you did a great job of explaining it, actually. So I do get a lot of patients that complain of an internal tremor. And what that means is exactly what it sounds like. Patients feel like they're shaking on the inside, but there's no visible tremor on the outside. Some people feel it in their chest. Some people feel it in their arms and legs. Some people feel it when they're standing and they just feel vibration. But I have a lot of patients that describe an internal tremor. And based on what you're telling me, if it really is at the end of your on time when you're starting to go into your off spells, is it sounds like that's a wearing off phenomenon for you. Now again, it's only a matter of time till somebody puts the next question in, which is I don't feel on. I don't. What are these on off things that people talk about? What are these? I don't know what that means. I feel the same all day long. Not everybody feels on and off phenomenon. So on and off phenomenon are when your pills kick in and they work, you feel better, and when they wear off, you don't. And so a lot of patients do experience a wearing off of their pills where they feel stiff and slow and shaky, and they don't move as well until their next pill kicks in. That's what we're talking about when we think about traditional on-off phenomenon. Not everybody has that. You don't have to have that. That's not a prerequisite or mandatory, but a lot of people do. And so if you're noticing that internal tremor as your pills are wearing off, it's probably a wearing off phenomenon, and that's the beginning of your off times. And again, tremor does not have to be visible. It can be any type in any body part, and it can be internal. And it does not have to be visible. And just because nobody can see it does not mean that doesn't mean it's fake. That doesn't mean that you're making it up. That doesn't mean it's not real. It's just an internal tremor. It's more of a sensation of vibration or tremor than an outward exposure of it. And it's just, and I treat it exactly the same as if you were literally shaking right in front of me. Hmm. I don't know. What percentage of people with Parkinson's disease experience foot drop? And is there anything you can do to prevent it? I would argue that foot drop is not a true or traditional Parkinson's disease symptom. You typically get foot drop in the classic sense, which is weakness with picking up your foot, from one of two things: compression at the peroneal nerve, which is right on the outside of the knee, or a lumbar spine problem. These are the two traditional areas that affect the nerve that allow you to pick up your foot and lead to what we would typically describe as a true foot drop. Now, people with Parkinson's disease do get dystonic posturing, where their foot turns in or they drag their foot, which can be called a foot drop too. And so there is a lot of overlap here in terms of what it looks like, but I'm actually not sure of what percentage of people. And what can you do about it? So if it is a true Parkinson's symptom, then theoretically you would try medicines. And so if it's dopamine responsive, you would try adjusting medications to see if you can work on that. If the medicines don't work, I do utilize a lot of, again, and my patients know this, or you guys know this, I utilize a lot of physical therapy and occupational therapy. There is something called an ankle foot orthotic, which is basically a flat piece of plastic that sits in your shoe, goes up your ankle, and it keeps your foot up, held up. And that tends to help people pick it up and not drag their toe, which in turn leads to tripping on things. And so again, if it's not dopamine or medication responsive and we can't adjust medicines for it, and even if we can, I'm probably going to be sending you to physical therapy to see if we can work on that. And they may recommend an orthotic. What do I know about Medtronic's brain sensitive, adaptive, deep brain stimulator approved just last month, said to be more personalized? Well, so the Precept has been around for a little while now, and this is a recording deep brain stimulator. So at the end of the day, when we put wires into people's brains, not only do we stimulate, but you can also record from that areas. And it turns out we have found specific or some markers in terms of frequencies and different changes in the circuitry patterns when we do that. The newest step is this. So they took that model of the deep brain stimulator that was recording, and now they're using it to then try to help the person who is adjusting the DBS maybe come up with the parameters a little bit better in terms of which contacts to use, what stimulation parameters might be beneficial. And if nothing else, it sort of makes the job of the person who's initially doing the programming or who's adjusting the programming quicker and easier. I haven't seen it used yet myself in any of our patients, but I think that's the idea for it, is that it is supposed to kind of measure your symptoms and measure the recordings in the brain, these local field potentials, which are basically kind of signatures right around the leads that tell us what's going on in the brain that then in turn lead to the symptoms, and using those to help the programmer more personalized or more correctly or quickly or easily adjust the deep brain stimulator. I think it's useful. I think the more useful step will be using this technology and taking it one or two or three steps forward, which is a self-programming DBS. But these are the steps that you have to go through to get to that. So we're definitely making strides in getting to what I think we all deem as the holy grail for deep brain stimulator surgery, which is an implantable device that records, learns, and self-adjusts, preferably is all up here, so there's no battery pack in the chest, that's wireless or controlled wirelessly. I mean, I think this is anybody that I talk to or anytime I go to the companies, this is what everybody has on their mind. And I think this is taking what was there from Medtronic, which was the measuring or the recording device, and taking it one step further to try to now help us adjust. Again, it's good and I like it, but I want to see those next iterations to really get us towards what I'm hoping is coming down the road. I recently experienced this twice, throwing up, and had to go to the hospital. I explained to the doctors that I had Parkinson's disease and they said I had hypertension or food poisoning. I'm baffled that hospital doctors would not have the knowledge to know this. I'm interested in the medicine Gocovri and would like to, there's a lot in here. Um, so I actually just had this a not exact conversation, but a very similar conversation with a patient that I had today. Um, while Parkinson's disease is well known, I mean, I don't think you'll run into a doctor, even an ER doctor, who doesn't know of Parkinson's disease. Your average doctor, ER doctor, surgeon, primary care doctor, is going to have basic knowledge and understanding of Parkinson's disease. They are not going to have neurologist knowledge or subspecialist knowledge of Parkinson's disease. They are not going to know all the ins and outs about Parkinson's disease, the non-motor symptoms, the GI problems that come along with it, the medications that come along with it. So the patient that I had today was upset that at his assisted living facility that people were mistaking when he said he was freezing for being cold. And everybody on here is like, yep, I get that, right? I would be mad too, because when I say I'm freezing, don't hand me a coat, which is what was happening. But and I tried to explain this, is that you guys are the experts. You guys know more about this disease than anybody on the planet, even more than I do, although I think I know a lot. But once you get one step away, you get to people who are working in a skilled nursing facility or an assisted living facility. Even if it's a nurse, the knowledge gap is huge. the training in these people on specific disease processes, particularly the ins and outs or the less common knowledge, is none. And so while yes, it would be nice if your ER doctor was able to recognize that, hey, you have Parkinson's disease, and that means your entire GI system slows down, including stomach emptying, which often leads to nausea, as does the medicines, they're not going to know that. And while you can get frustrated with that, as I think a lot of people would, the alternative is you could educate. And so in a kind fashion, say, yep, this is kind of what I have with Parkinson's disease. My GI system slows down. This is what leads to constipation. But it's not just the large bowels. The small bowels are slow. The stomach doesn't empty very well. The swallowing is off. My medications also make me sick. The more you educate the people around you, the less likely they will be to hand you a coat when you say you're freezing, and things of that nature. And so realistically, and I run into this too. Don't get me wrong. I run into this too when I'm talking to patients or I'm talking to other providers. I often forget how much I've learned over the time I've been doing this and how much they haven't learned because they're not doing this. But you have to keep that in mind, is that you will run into ER doctors or nurses or medical assistants or aides who do not have the knowledge that you do of the disease that you're dealing with. And so at the end of the day, I'm not surprised by this, and you will run into this not infrequently. And you could get frustrated with it, or you could take that time to try to educate and see if you could explain things a little bit better. I'm not sure if the question about Gocovri is related to the nausea or not. Gocovri is a extended release amantadine that is really approved for the dyskinesias of Parkinson's disease, but also helps with some of the motor symptoms. And so again, if you wanted to try it for your symptoms or for whatever reason, you need to talk to your doctor. But again, coming back to the original question, you will run into people who are not well versed in this disease, especially beyond the tremor and cinnamon. I mean, that's just going to be a fact of life. Have you seen patients that go into total body freeze with normal blood pressure that lasts for a couple of hours? How would you treat it? I have. I mean, it sounds like that's an off time. I mean, again, especially if it's not blood pressure related or heart related or something like that specifically related, it sounds like a bad off period. I have people who are off hours of the day where they're really not moving very well. The first thing I would do is correlate it with medicines, see what we're doing medication wise, see if we can adjust for it. Again, there's not necessarily an easy solution for that, but I would try treating it based on what's happening. And I would probably first try, if somebody came to me with that, ramping up the medicines to see if we could kind of unlock you or limit those off times. But I have patients where the off times are not responsive to medicines very well, and they're very challenging problems. Hmm. You frequently recommend drinking more water. Does this help Parkinson's disease, or is it to help side effect? Probably all the above. So drinking more water is just a universal in my patients. Most of my patients are dehydrated. They don't drink enough water. They don't eat enough. And part of it is, again, what I just mentioned. The stomach emptying is slow. Food stays in your stomach. You stay full longer. I hear patient after patient after patient who says, I never feel thirsty. I'm never hungry. I only eat and drink because my wife makes me. And so I think it's just good for overall health. If you're dehydrated, everything gets worse. And so I think it not only helps with Parkinson's disease, but also probably helps with some of the side effects of the medicines too. And it's just kind of good overall health for what we're looking for. That's a great question. What are the long-term effects 20 to 40 plus years of Parkinson's drugs, carbidopa, levodopa to the gut or the rest of the body? It depends on who you ask. I mean, realistically, we don't know. Not that levodopa has been around for just going on 70 years. We've had plenty of patients who have been on it long term, but to say that we know what it does to the body, I think is a bit of a stretch. We don't think that it's necessarily toxic in terms of speeding up progression or end organ damage. But at the end of the day, I mean, there's got to be some sort of ramifications to being on a medication that is not natural for that long. um, I think we just don't know, or we haven't necessarily figured that out. The other thing you have to keep in mind is that, again, that's going to be a really hard test to do, because not only because you're probably not just on one drug for 20 to 40 years, but you also have a neurodegenerative condition that progresses and changes over time over that 20 to 40 years. And so it is often very, very difficult to say, what is the side effect of the medicine? What is the side effect of the disease? What is the side effect of aging, which also comes with that time? And so that's a really hard study or hard idea to come up with. Again, there was a time where, at least in cell model or animal model, we thought levodopa was toxic and that it sped up disease progression. We've done enough studies and we've had enough long-term uh, kind of following people that we don't think it does that. But at the end of the day, I don't think we can confidently say without a doubt that it doesn't have some sort of ramification or side effect. We just don't know. And again, I think we don't know, and this is going to be true for every drug known to man because that's a really hard thing to kind of prove or study. Do I believe that microdosing levodopa is the way to go versus 3 or 4 times per day? Yes and no. I mean, I think according to studies, and so this comes back to the new pump, Vialev, which gives lower doses of carbidopa or levodopa directly subcutaneously 24/7. There's been published reports about, the side effects of levodopa are directly related to the pulsatile nature of taking pills. And I kind of go over this by saying, at the end of the day, your brain or my brain doesn't naturally just put out bursts of dopamine 4 times a day and then it wears off. But that's what we do with the pills, right? You take a pill, you get a burst of levodopa, and then over the next 4 to 6 hours, it wears off. That's a very unnatural way to replace or deliver a chemical. And we think that the dyskinesias and the fluctuations and maybe even the hallucinations are side effects of that delivery method. And there have been some studies to suggest that when you do the old intestinal infusion or the newer subcutaneous infusion, it does significantly take down those side effects. And so would we be better off if we went to that first? I don't know. I mean, at the end of the day, that idea has been floated. I'm not sure, if they've actually done that study or looked at it, but it does seem interesting and intriguing to me. I'll have more about the pump after I use it a bit more. Again, it's not approved for the vast majority of my patients, and so more to come. Although, again, it's been used in Europe for a while. I think there is something to it. Do I think it solves all the problems? No. But do I think it could be a better delivery method than the pulsatile nature of the pills? Yeah. And so I think more to come on that once we do it a little bit more. Go ahead, Donna.
Yeah, I just wondered, do you have anybody microdosing with pills?
Sort of. If by microdosing, and I guess, so I have some people who dissolve Cinemet in fluid and literally take a drink or a shot of it every hour. That would be microdosing. Now, at the end of the day, we usually get to that point after a long time of being on it and having fluctuations and really needing it that frequent. And believe me, that's not the goal when I'm treating people, but I have people that do it. Would that be better from the start? I don't know. The only people that I've had do that kind of dosing schedule have had Parkinson's disease for a really long time, and that's how we end up on that strategy. But again, the idea has been floated out there in the literature that, especially with these new pumps that are available, could that be a better delivery system or people do better with that long term than the pills? I think there's enough logic there that I think it makes sense. I think more to come.
The other reason I asked that, when the Parkinson's Foundation had Jimmy Chu speak, the Ninja Warrior,
Mhm.
I didn't get to ask him. I did get to ask him this, but I haven't heard him speak on this. But he takes Divi and he just takes it when he needs it or something about that. But he had it for a long time and was bad. And then he was able to get better. But I don't know how he doses his levodopa through that process.
Yeah,
And
and I'm not sure either. And again, I have some patients that take Divi when they're splitting things, more precisely. But I'm not sure.
but they're not microdosing it. Like they take a quarter
Mm-mm.
every hour or a quarter every when they need it, or is it on a time schedule?
No, I mean, I have some patients that take it as needed, but I don't know that I have anybody who microdoses like that. Again, I don't know that it's ever been looked at.
Okay, thanks.
As the patients get to later stages where they can barely stay awake, do you just let them sleep or try to force them to stay awake? I mean, there's no right answer to that question. It comes down to what you're trying to accomplish. Um, Ideally, we would have people more awake, right? More alert, more interactive, more stimulated. But how much of a fight do you want to put up? That really is what the question comes down to. Maybe sometimes if people are coming to visit, you try harder, and if you're not doing a whole lot, you let them sleep more. There's no right answer to that question. It's very, very subjective. I don't think you're doing damage or benefit one way or another by the time you get to late stage disease. The cat's kind of already out of the bag, and so it's whatever makes sense for what you're trying to accomplish. Right? In December in Pennsylvania, we're having a lot of painful cramping, and sure enough, we go down to Costa Rica and the temperatures are in the 70s. Ha, cramping gone. I think it's a lot weather. I mean, it's Parkinson's related, but I hear a lot of people. This has been a bad winter. This has been an extremely cold winter. Everybody has had trouble. They've been stiffer, they've been slower, moods have been worse, symptoms have been worse. And again, I was actually just down in California for a very short time this past weekend doing a speaker training for a different company, not Parkinson's disease related. And it was 60s and sunny. And I was like, they have to be doing better here than we are in Pittsburgh, right? Just the sheer amount of sun, the ability to get outside and be active. There's got to be some data somewhere that suggests people who have more sun, more temperate climates do better. Because here we get gray, we get cold, we get snow, and it's depressing. Seasonal affective disorder is real. B, you can't get out and be very active. C, everybody tends to stiffen up and cramp up when they're cold. There's got to be something to it. And so the short answer to your question is it's probably Parkinson's, but weather definitely plays a role in terms of how your Parkinson's manifests. And so, yes, it would be nice if we could all have 70-degree weather all year round. I think I would do better with that as well. Uh, I'm really bad at this. So with something like the question is with something like cancer, doctors will give time frames, 6 months to live. Is there ever a point with a more severe or atypical form of Parkinsonism that I put a time frame on it for families to prepare, or is it really that uncertain? I would like to say it's that uncertain, but I would also say that I am just not very good at transitioning that discussion. And I'm also, even though I'm very pessimistic when it comes to studies, drugs, research, I'm also very optimistic when it comes to the office clinic in terms of what can we do to see if we can get you doing better. And so I would argue that one of my downfalls, one thing I am well recognized that I am not very good at is transitioning that conversation in terms of when do I say you only have 6 months to live, or really getting people on hospice and palliative care as I should. It's a fatal flaw of me. I'm working on it. I do think there's a lot of uncertainty in this compared to things like cancer. I don't think that the things that the Parkinsonisms lend themselves consistently enough to give those types of talks, but I do think there is room for me to do better and us to do better as a whole in terms of when to kind of transition that talk or give people that kind of ultimatum. Again, I don't like to do it. I'm not very good at it, but it's a work in progress for me. Are you even considering that Parkinson's is caused by individuals' trauma, stress history? Patients should consider hypnosis before medicines. And if their symptoms improve in this relaxed state, they should consider other approaches, deep relaxation, so on and so forth. I actually did have one person who used hypnosis to treat his Parkinson's disease, and he actually did really, really well. And so, yeah, I don't begin to say that I know what causes Parkinson's disease. And I do think it's a combination of a whole lot of things. Nonetheless, individual trauma, stress, and history. And so I think it's a great idea. I'm never against it if people want to try those techniques. I'm also not against it if they want to use those techniques in conjunction with medicines. It's whatever helps you do better and feel better, and less medicine is always best. And so if we can get away with hypnosis or deep thinking or you kind of those types of meditation, I'm all for it. I don't know that I necessarily know enough about them to recommend them or really have in detail or in-depth conversations about the ins and outs about them, which again is probably a flaw on my part. But if people bring those ideas to me, I'm never against that idea. All right, I got a couple more questions and then I'll hold on, Donna. Let me finish these questions and then you can talk because I'm running out of time. Memory loss has been the most notable symptom that my husband is dealing with lately. Does it always come with Parkinson's disease? Or could it be a side effect of the medicines? And so the short answer is it could be both. Not every patient that I see with Parkinsonism has memory problems, but I would say the vast majority do in some way, shape, or form. And it can range from just a slow memory that typically comes with aging, like I see somebody and I can't remember their name, comes to me a few minutes later, I just can't come up with that word, to full-blown Alzheimer's type dementia. And there's not a good way, at least that I've been able to find, to actually predict that. But you do have to take into consideration medication side effects because a lot of the medications cause fatigue, can cause brain fog, can cause blood pressure fluctuations. And so at the end of the day, we have to keep that in mind as well. And those things are really hard to tease out. You really do try to figure out side effects of medicines by changing them versus just disease progression and then using other medicines. It's something that we definitely have to kind of keep in mind. I do think the Medtronic Future Road is in our lifetime. I don't know. I don't know. I don't know how far in our lifetime, but I think it's in our lifetime. All right, two more questions. Is Rotari a good nighttime med? Sort of. So Rotari is carbidopa, levodopa. It's immediate release and controlled release in one capsule. Again, at nighttime, I do try to use the longer lasting versions because at night you don't necessarily need to feel it work as well, but you need it to last a little bit longer. So I'm not against using Rotari, or sometimes I use a Cinemet CR, Crexont being the newest version. There's definitely some reason to use it at nighttime to try to bridge that gap overnight until you wake up in the morning, but I also use it during the day as well. The Cinemet CR is the one I usually use predominantly at night because I don't think it works all that well during the day. But Rotari, I think, works okay during the day in some people, but I think it's a reasonable nighttime med as well. All right, last one, then Donna, you can talk. I have stage 2 Parkinson's disease, REM behavior sleep disorder. So far in June, I've had incidents where I end up on the floor 34 times. That's a lot of times. 2 pills of what are my options to keep me in bed? Well, actually, I think there's a couple options. So one is there's other medicines. I use melatonin, I'll use clonazepam, again, some of the other medicines, but the other thing is bed rails. Bed rails, a lot of my patients use bed rails. Some people throw themselves over the bed rails, don't get me wrong. In which case maybe you just need to lower your bed to the floor. Kind of structural things are also ways you can try to work on that because you certainly don't want to break something because you throw yourself out of bed, which I have had in my patients. And so in addition to medications, which there are a couple of other options, structural supports are also really good. So you can get bed rails on Amazon. You can lower your bed closer to the floor. If push comes to shove, you sleep on the floor because at the end of the day, you can't fall out of bed if you're already on the floor. Again, not ideal, but things to keep in mind. And so that's how I would discuss it, if you bring it up with me. And with that, that's my last question. So Donna, what were you going to say? Go ahead.
I mean, if we go with the hypothesis that it's caused by stress or trauma, in that case, if you go after that approach, levodopa is kind of toxic because it turns into adrenaline, which is pushing you into that stress state. So to get out of that stress state, you have to go into a hypnotherapist or do stuff that changes your rules and your psychotherapy on relaxation. And if you're feeding adrenaline 24/7, if overnight you're getting stuck in that state and it's not letting you get out. So in that case, I do think levodopa is toxic. So if people want to go after that route to cure their symptoms before they go on medicine, it's a lot easier. Once you're on the medicine, you kind of have to get off it to go after the stress reduction because it's feeding you adrenaline. But then it's a stressful thing in itself.
Yeah, we just haven't proven that. I mean, at the end of the day, there's not enough evidence to suggest we know why people get Parkinson's disease. And so, well, it's not a bad idea. I'm never against that idea, particularly early or in minimal symptoms when maybe the symptoms aren't bothersome and we don't have to be in a rush to put you on medicine. I think they're great strategies. And I think this comes down to we really still have work to do to figure out why people get Parkinson's disease. And I think the closer we get to that answer and the more information we get about that underlying cause, it's going to lend itself to stuff like that to either fix it, prevent it, or really do things before we get to just symptom management, which is all we got right now.
Or before labeling that you have a chronic disease that will not get better.
Sure. All right. Well, with that, we will end. Casey, I'll pass it back to you because I don't remember when the next one is, but you probably do. And I'll let you wrap us up.
Thank you. Our next one is on April 3rd, thanks to Karen, who always reminds me. And please join in our other virtual programs, in-person programs, and hopefully the conference, but we will see you before that on April 3rd. Thank you, Dr. Leichliter. Thank you, everyone,
Thanks,
for
guys.
attending.
Have a
Bye.
good night.
Good night.